Hi everyone, and welcome to our last webinar of the year. Just before we begin, I'd like to acknowledge the traditional custodians of the land that we meet on today and pay respect to elders past, present and emerging. Today is infection prevention and control measures as good practice, and we have our wonderful presenter Marg Jennings with us again. So we'll get started. Don't forget, if you have any questions, that you can type them into the question pane and we'll answer them throughout the session. Thanks, Marg.
Okay, thanks, Jenny, and welcome everybody, and thank you for sticking with this for this year. Who would have believed it when you came back from your break in January this year? I know you're on code green or lack of code in New South Wales. I'm in Melbourne, but I'm seeing a real disconnect. They're ripping their masks off. That's okay. They don't have to wear their masks outside here, and only inside in the bigger stores and supermarkets, etc. And you've got to put your name down, of course, if you're at a cafe or something like that. However, even when there are no masks, the requirement is, and I'm thinking about your practices, because you go, God, we don't have to wear our masks anymore. I'd be wearing a mask, sorry, because I know what I see in practices, and I don't see people distancing. Certainly if I'm the doctor or the nurse attending somebody, I'm wearing a mask. I think you can probably ditch the eye equipment. I don't know exactly what it says there, but the measure you take has got to be proportionate to the risk. But I'll tell you what, who wants a tap on the shoulder or a message on your phone to say you were a close contact of somebody because you didn't keep your distance? So thinking about work, why would I have two receptionists at the front desk? I know that they can't keep 1.5 metres apart, and this is the requirement. Until there is no global pandemic or until everybody's got the vaccine, this is the requirement. So if I were you, I'd make life slightly easier for myself, quite frankly. And at the front desk, if I do have to have another person at the front desk, I'm not going to be so obsessed about the 1.5 because it can actually be a bit difficult. So you can see it's not just ditch everything, it's you're still expected to keep your distance. And if that's difficult to do, you wear a mask, and especially inside. You see, we have to do that if we can't keep our distance outside here. So a lot of clinics are contacting me and talking about this hole that we've fallen into, which is what do I do, what do I do? So the measures are not changing, and that is 1.5 metres, obviously cover up, hand hygiene madly, don't come when you've got any symptoms at all, any symptoms. And we are here. I had somebody at my place a couple of weeks ago, runny nose, doing some outdoor work. And I said, Andrew, oh, it's okay, Mark, I had a test, I'm negative. And I go, yeah, but what are you doing here? So what is it that the public haven't understood? Oh, I can still come to work with a cold because it's not COVID. No, you've missed the point of the whole year. We don't go out when we've got any symptoms anymore. Oh, he said. I didn't send him home. If he'd been inside, I would have. So you see people are saying, I've had a test. Oh, even though I'm not fantastic, I haven't got COVID. Isn't that good? And the rest of us are going, keep away from us. So I'm really disappointed that people would miss the main message of this year, is that we don't actually go out when we have any symptoms because we know it transmits to other people. And I wouldn't thank him if I got his cold. So, you're going to hear this from your patients. Don't worry about my runny nose. Yes, I've got a bit of a sore throat, but I've had a test. It's not COVID. Well, thanks for nothing for passing it to me, the nurse, me, the doctor, me, the receptionist. Because guess what? I'm not keeping my distancing. Everybody's dropped their guard. So don't put yourself in the position of something being readily transmitted, whether it's gastro, peak gastro happening in Melbourne at present. What does that tell you? Everybody's back to, smooching and when they shouldn't be, and just not taking those precautions. So I don't want you to be schizophrenic about it, but the fact is we keep distancing. That's what we do until there is a cure or vaccine or it's run its course. And I look at my covidlive.com.au every morning at about 10 o'clock, and every day for the last months and months since January, We have always had cases in Australia. Of course, we distinguish between community transmitted, and right now there are, in terms of testing, we have not picked up any community transmission, certainly in Victoria the last 43 days. New South Wales, I think you've had one recently, and I know that you had a cluster a little while back. But every day, there are 8 to 18 people becoming positive in quarantine. Sure, they might have tested negative at Heathrow Airport or San Francisco or Mumbai, but they're cooking it. And of course, they're on that sausage machine called the plane. So bingo. So we're getting positives nearly every day in Victoria since we opened up last Monday. No surprise. My concern is the doctors are permitted to, no other profession is allowed, but the doctors are permitted to work in the hot hotels, if you like, the medi hotels, and they're allowed to do 1 day's practice a week in their own practice. Now, they are our risk. It's not a case of isn't that terrible or they shouldn't. It's a case of they're our risk. You must recognise your risk. So if you have a doctor in your clinic who's also working, you know, a few shifts a week at the medi hotel, they are our risk. And they need to be just unbelievably good at putting on and taking off PPE. And I need to tell you that 30% of the time people remove their PPE, they self-contaminate. Not removing gloves properly, and believe you me, I've seen enough of it. So you've got to have confidence if you're sharing a clinic with somebody who's also working in those hot hotels that they are your risk. And of course, as soon as, you know, that then ups the risk for you guys. So it's not about saying, oh, we're really good, or that doctor knows what to do, or that nurse knows what to, sorry, your risk is higher if you're sharing a space with somebody who is also working in the hot hotels. So, you know, this is about accepting risk and managing it. So what am I doing at my clinic? I keep my distance. I don't have any more than, you know, 2 or 3 people in the tea room, preferably outside. Always go outside when you can. You know, people are on my, you know, hammering on my email saying we want to have patients back for long consults. And I go, outside, in the car, a little bit outside, a little bit inside. Oh, you know, we want to have it like it was. And I go, sorry, there's still a global pandemic going on. How much can I do telehealth? This is on the one person. I can do a little bit telehealth with that person. No, I need you to come in. They come in, I see them in the car. No, I need you to come inside. But you've already cut what's a 20 or 30-minute consult more than in half in terms of your face-to-face with that person. And I tell you what, you'll thank your lucky stars the day that that person turns out to be a positive, and you've cut down that close contact to less than, you know, 10 minutes or so. That's the position you want to be in. Now, having said that, and in case you think I'm a hypocrite, I'm on the 4 o'clock plane up to spend a week with my mum up on the Gold Coast, you know, if it'll land with the weather. So I had to think about where I'm going to sit, window seat please, and there'll be no food or beverages served. Smart, that's terrific. But if I see anybody with their mask below their chin, you wouldn't want to be on the same flight as me. I'll be pressing that buzzer big time, because that person is exposing the rest of us unnecessarily. But I can just hear the comment, oh, but there's no COVID around, what are you worried about? And I go, yep. Well, that's what they probably said last Saturday when the mother and son flew from Sydney to Melbourne. End of story. And not much fun when you're told initially you might have to quarantine for 14 days. So I'm going to be wearing a P2 mask on that sausage machine today, I can tell you, and I won't be taking it off. Okay. Obviously, if you've sort of checked in, you'll see that there's a bit more work to do when you complete that. So the airlines are taking it seriously. I'm taking it seriously. What's happening at your clinic? Now, part of the areas, what did we learn this year? Well, we actually learned not to come to work with symptoms. Now, what about our patients? I wouldn't be having walk-ins or people booking online. I mean, you know, they don't even read all the questions about symptoms. I'm on the phone to them, and I'm saying to them, if you have any of these symptoms, not just are you well, and let's do a temperature check. I think we've done temperature checks on the contactless I've had my say on those. Don't just rely on that. If it's low, take no notice almost. Go on the symptoms, especially if the person's taken Panadol or something like that, which lowers temperature. So what did we learn? We learned that we're not to come to work when we've got symptoms. We've learned that nobody comes into my clinic unless I know their symptoms. Now, if that person does say, I've got those symptoms and that's why I'm coming, see them outside first. I mean, obviously you've got to be smart, and if the person's really, really, really sick, it's an emergency. And again, the doctor may choose to come out or the person may choose to come in, but they're going to have a mask on. So I'm assuming that in the general practice that patients are wearing masks when they come in, because I tell you what, again, you'll thank your lucky stars. Somebody slips through, they got symptoms, didn't have a mask on, sat down. And you say to me, oh, but Marg, all the patients are 1.5 metres apart, and I look in your waiting room, all I see is aircon blowing droplets from that person all over everybody else. 1.5 metres is not enough in that case. No air exchange, no fresh air coming in, and then I see two receptionists and I go, bingo, almost close contact. And of course the patient waits not for 5 minutes, the patient may be waiting for an hour, and that just ups the risk in that whole waiting room. So let's actually avoid that. Let's be smart, and that's why we want to know the patient's symptoms. And you say to the patient, oh, it's not that we won't see you, we just do it a bit differently. And also ask anybody in the patient's household with those symptoms. And same with us. Don't come to work if somebody in your household has symptoms. There's only one place for that person. You take them to get tested, and you know that you guys will wait until you get the results. And we're down to about 18 hours to get the results these days. Of course, you can come to work as long as you don't have symptoms. Okay. Also, so the measures to keep up, yep, distancing, symptoms, no. Hand hygiene. Hope you're looking after your skin. Lots and lots and lots of hand cream, please. When I say lots, 2 to 4 times a day. So please keep up those measures. One of the questions that people ask, thinking about what next year might look like, would be to think about the vaccine. So here are the two things that we don't know about the vaccine. The vaccine should work. I mean, if I was mean, I'd say that Britain or the UK is in fact the trial, the guinea pig. So you know that they've started to roll it out. And rolling it out in winter is quite smart, actually. And so we might actually see if trains of transmission can actually stop. And I know that sounds like a terrible experiment, but this is the vaccine. This is when it's become available. We use it now. We don't wait, and it couldn't have been any earlier. So we'll actually get some, I think, good data from the UK in the next, say, 3 months. But in my world, in my dreams, I turn up for my flu shot on the 1st of May in one arm, and I get my COVID shot in the other. That's my dream. Okay, and of course I come back 3 to 6 weeks later for my second shot of COVID. That's if it's shown that we can actually get them. So it could be that supplies here are held up, and it depends. We're going to be doing some manufacturing here ourselves. And of course, there's always a few hiccups when you sort of do that scaling up. So that's my dream. 1st of May, that's me. All right, we'll see. Not happy to take bets, but that would be what I would really like to have happen. But that only means, I think it's people over 70 first, healthcare workers I think are included, and then I think it's over 60s. You know, that's in terms of the public, that's the way they're rolling it. But I would say they would put healthcare workers in the vulnerable, you know, the younger cohorts, the younger on cancer treatment and on immunosuppressives. They would be up there first too. So it would take probably 3 to 5 months to roll that out in Australia over our winter. It may be that they even have to choose one state over another. And so you might say, well, it's, you know, colder months in Tassie, so you know, this is if it comes to the crunch, that it may get sort of rolled out in the cooler climates over winter if they can't get it happening till about June, July. So what are the two things that we don't know about the vaccine? We don't know how long immunity lasts. And the only way you know that is when people start to get reinfected. And we know that these vaccines are around 90, 95% effective, so that's not going to be the issue. The type of T cell, you know, memory response seems to be good, but you don't know how long it will last, immunity. If it's anything like a norovirus, gastro, even the old SARS-CoV-1, it doesn't tend to be long term. So yes, it could very well be in the influenza bucket where you get a new one each year. We don't know. Remember, this is a virus that we didn't even know about a year ago. Secondly, we don't know whether the person who's been immunised, when they're actually faced with the virus, it's got to actually come in, do some replication, and then your body recognises it and jumps on it and neutralises it. We don't know whether in those few days, even though you don't have symptoms, we don't know whether you will be infectious to other people. Hence the reason for everybody being immunised and us getting to some semblance of herd immunity that way. So they're sort of, and there's a messenger RNA, that's the one that's got to be kept at -70. I think the one in Queensland and I think the one in Russia, they might be the adenoviral ones. There are different types, okay, of vaccines, but those 2 or 3, Moderna one, I think there are 3 main ones. And even what we've learned from the Queensland vaccine, we should be able to learn from that and actually not just get rid of the whole thing, but build on it. And who knows what we'll actually find out about the actual virus from what has happened. So we don't ever sort of throw away research results. So what will next year look like? Well, we are accepting 40,000 returning Australians. They're not people who've just decided to jump on a plane and escape to Australia. They're citizens. And they might be your sons and daughters. They might be my neighbours who have been trying to get on a plane even since January, February, some of them. Kids whose visas have run out and they've certainly got no money. Families whose job has stopped and they've been waiting and waiting. So, of course, they've got the right to come in. What you might argue is it appropriate for people to be flying during a global pandemic? Well, I think if the fatality rate, the mortality rate had been a lot higher, I would have been a bit more edgy saying stay where you are. But we believe we can manage incoming flights, we believe. Let's find out. There's always the human element, as we know. So I'm thinking about these 40,000, and as the figures go up in Europe, more and more will be positive when they're doing their 14 days in Australia. More and more. More and more, and there'll be more than 40,000 not wanting to come back, but seeking to apply to come back. Okay, so it's not a holiday. People, they're citizens who are applying to come back. They represent our risk. So again, it's not about being mean. They are our risk. So if you can't address risk, if you don't even know where the risk is, you're in deep, what here. So that's what you have to be brave enough to say. So many in Sydney, I think it's 7 in Sydney today from flights that have come in the last fortnight have turned positive. Now imagine that's you're in the hotel room, or maybe it's an apartment with your 2 kids and your partner. And on day 3, one of you tests positive. And I don't know whether it's the system in New South Wales, but it's common for that person who's positive to actually go off to, the positive hotel. There are fors and againsts for that, you can imagine. But of course, another 3-4 days, maybe a child tests positive. I really just don't know how that is being managed. I'm not being critical, I'm just saying I actually don't know how that's being managed. But I mean, the mental health aspect is also huge. And I suspect that a lot of the doctors managing patients in the Medi hotels are dealing with a lot of mental health issues, because people are, euphoric at the fact that they've got a seat on the plane to come back to Australia. And then I think the reality when they hit here, stuck in one room or maybe 2 rooms if they've got kids. And I won't comment about the food, but I've heard enough about it, and that's a bit tricky because you can't sort of like serve meals on plates. Everything's got to be covered. So I won't talk about the donuts and I won't talk about the pies, okay? So have some sympathy for people. Don't just say to them, you'll be grateful we let you back in. I don't think that's a really good attitude. And so they're euphoric, they arrive back and bingo, on day 3, so one of the family tests positive. So your world sort of starts to crumble. Not only that, you're jet lagged. And anybody who's come in from the UK, etc., knows what you're like on about day 3. And then, we don't have a job to go to, or worse, we don't have a home. So a lot of issues, I think, you'll be dealing with. And so there'll be people who did their quarantine and then they're seeking an appointment with their doctor in Newcastle or Armidale, Tamworth, Dubbo, and that's their story. And that won't be the story for 40,000 people, but I would expect more than a few hundred will be positive out of that. Now, people say to me, but Mark, they're all tested at the airport, or I think they've got to be tested within 48 hours of the flight and they're negative. I go, yeah, but they're often having those quick 15-minute tests, which they're not going to pick you up in the early stages of your infective period. I think they pick you up in the 24 hours beforehand, but you could be infectious 36 hours, as we know, possibly even up to 48, but we're saying around 36 hours. It's when you're fairly able to transmit it. So, of course, the test they're having at the airport, or the quick test, the rapid antigen test, that won't really tell me if they've begun to be infected and just become infectious, because it's not as sensitive. It also may even go negative even before your symptoms have disappeared. So we know that the PCR test is the gold standard, but it's really just not feasible to use the PCR test, which, as you know, takes 6 hours to do. So it's a day before you get your results. It's really not that feasible to do where you've got massive numbers positive every day. And that's what's happening in Germany, England, America, India, etc. So don't be down on people because they've had a rubbish, antigen test. The antigen tests are fine when you're in that situation of it being a large outbreak. Here in Australia, it's not adopted. There are a couple of specific circumstances, but it's not really adopted here, and it's not necessary here because we have very low numbers. And we can do the testing very quickly. But where your testing turnaround is really slow because you've got thousands and thousands and thousands. And this is almost the point we got to. In fact, we possibly did get to the point in Victoria in July where we probably didn't get all the cases. And that's why we had the measures, the extra things that we all did for 12, 13 weeks, and we did it. So there you go, some credit. Now, what I've done is on my website, and Jenny, it's just Margen, margenes.com.au, Margen Education Services, that stands for. I've actually put up my November e-newsletter. Don't laugh, but I lost all of my 2020 work about 3 weeks ago because my computer just decided to go kaput, and that included all my emails. It was actually a very liberating experience. Obviously, there was enough in here for me to remember, but I lost all my contact details, or contact lists. So if you feel you want a personal email from me, all you've got to do is email me and I'll put you back on that list. But what I put up, it goes over to 2 pages, which is against my, my mantra of 1 page is enough. There are 26 little points. Now you can cross or tick. You can say, I don't want to do that, but I'll just put number 1. Do you do this? Staff are checked by a colleague on arrival every day, not just a temp check, but a full list of symptoms asked. And you need to know what that full list of symptoms is. People often forget the nausea and vomiting. They may not even mention the rashes. Some people can get rashes, and that's more a neurological issue too. But don't forget, the fatigue, the shortness of breath, the rubbish throat, the dry cough, the headache. You might just have 1 or 2 of those symptoms. So even if you say to people, are you well? It's not enough. Yeah, I'm fine. They're probably happy hypoxics. I came in because I can't remember why I came in. So be very careful of just saying to people, are you well? Because they know that people with hypoxia are pretty happy, okay? They're not going to appear that unwell. There's going to be a big push next year, and even now, to be real, the GPs to be right on anybody who's positive and keeping a really close eye on them. So just because right now our positives are all in the hotels and they're from overseas, those people I think are going to have long-term issues. Sure, they're going to be released when they're feeling well, testing negative, etc. in fact, not everybody's even going to be testing negative. As long as they're well, that's going to be one sign. I just don't know how much more testing they're going to do with that particular person. So we say that if people are feeling well, that after even after 10 days, but we're testing them at 11 days. So right now it's 14 days quarantine. So as long as it's not community spread, we're still going to get all those thousands of people going back into our community, and they're going to be thinking, what have I been through in the last 2 weeks? And so you'll get, people with anxiety, depression, etc., as a result of that experience of being stuck in England for 4 or 5 months trying to get a seat. So I think you can see the load on general practice is going to shift a bit, and certainly the mental health issues will be there. What we're praying for is no third wave. Hence, we stay 1.5 metres apart, because once a wave starts, you don't even know it started in the early stages. And that is what caught us out in Melbourne. The start of our second wave, which came from hotel quarantine, was enmeshed in the tail of the first wave. Missed. Also, our contact tracing was, I won't say completely rubbish, but 2 things happened. It wasn't fantastic. It wasn't as good as the rest of the states. The guts had been ripped out of public health in the 90s. Thank you for nothing, a particular government. But I can say that governments of both colours didn't pick that up in the 20 years since. So you can blame everybody for not putting money into public health. And so we weren't the same. We weren't as good as the other states. But also there was no way we could be testing everybody. I would doubt that we were even getting 10% of our positives. I would say we were probably seeing thousands, not seeing thousands a day is what I mean. So the only intervention you've got then is to stop everybody moving, because there would not have been enough testing doing. And of course, this is the point that overseas countries have reached. They're barely able to do contact tracing, barely able to do it. Once you reach a certain critical threshold, it's not happening. I can't believe it, but my phone is ringing. And I'm not answering it. Sorry about that. So that was the first question. Are you asking, or do you just say, you're okay, aren't you? So we need to get a bit more serious about this. And then I've got in my question number 2. If a staff or household have symptoms, they're tested immediately and quarantined until results are known? The answer should be yes. Even if a staff tests negative for COVID, any symptomatic staff remain away until symptoms are resolved. This is the stuff that I think you can go through, and I think it refocuses people. So we're not sort of being scaremongers. We're saying, what part of a global pandemic do you think you're not engaged with? I'm being mean, all right. Now I keep a record. You can keep a record through your phone. I keep it through my diary of who I associated with. Okay, and I'm not associated with a lot of people still. I know we can have like 100 to our place on Christmas Day, but I couldn't stand it. And I've just got here, symptomatic patients are more safely seen outside or in their car, but do respond appropriately if they're extremely unwell. And it may be that somebody's got to be carried in and they haven't got a mask on and they're really, really crook. And unless you guys are all masked up, then there's your risk. So just put yourself in the position of saying that whatever happens to me at work today, I've made sure that I can stay low risk, because the option, if you do nothing, if you've not distanced, obviously around symptoms, any symptoms, I'll be wearing masks, but also if I'm close to people, including my colleagues, I've got my mask on. The alternative is to forget about it all, say it's all a pile of rubbish, say you've had enough of it, you can't stand it, you've not been told to do anything. Because see, people get restrictions mixed up with measures. Measures are the 1.5, the whatever. People go, oh, it's all over. And then bingo, you get somebody in there. They're under the radar. They've come in for something else. They sit there in the waiting room. The doctor's a bit late. They sit there for an hour. And you think it was good enough to have to have distancing. You've got the aircon on. There's no fresh air coming in. The doctor sees the patient. The patient goes, by the way, just got this real weakness. I don't know what it is. I've had a bit of a sore throat, or I've got a sore throat. And bingo, there you go. Face-to-face contact, 15 minutes without masks. That's close contact. you're going to have to close the clinic. That's the option. And you've handled that person's card, you got rid of your sneeze shield, or you've kept the sneeze shield thinking that meant everything and didn't care that people with symptoms were coming in. Bad news. So put yourself in a position of saying, I'm not going to have to close this clinic and do a deep clean, because there'll be sharks on your doorstep charging you $6,500 for a deep clean. I think I can walk you through one for not even 1/100th of that. In fact, I can just give you a sheet, and I did actually put something up on my website, how to do a deepish clean, and you guys can do it yourselves, but don't put yourselves in the position of even having to think about closing down. So be really smart about the way you conduct your clinic. Now, I'll give you another curly question. Windows are open to increase fresh air exchange. You know that being outside is 20 times less risk. Security screens are on open back doors. So a lot of people have had security screens installed on back doors, etc. Some also on their front doors. So the patients can't just walk in, okay, without having some testing done. Masks become wet. Now, this is a fact. Some brave people, or mean, I don't know what the word is, mean managers, have said, no, I give my staff 2 masks a day. And I go, so when they take them off, you know you've got to dispose of a mask when you take it off. You've got to dispose of it. So that means you're not drinking for 4 hours, you're not going to the toilet. Worse than that, and I think you've probably seen me show you this on the surgical mask, when these get wet, and here's the middle layer, when these get wet, you'll see a little drop. You can even put a drop of water on, and it looks like it's there with surface tension, and then it goes in. So that's somebody coughing or sneezing all over you, or repeatedly you're breathing on it, gets wet, no good. So my view is that might be heroic, 4 hours, but what's this doing to you mentally, and how many times are you touching it? Because every time you touch your mask, you've got to do your hands. In fact, can I say, one of the good things about having your mask on at work is it stops you touching your face, because that virus just wants to get in there. Again, you say to me, but Mark, we've got nothing around here. Then all of a sudden you get a report on the Newcastle sewage treatment work, bingo, fragments of RNA belonging to COVID, and you go, oh, we don't know whether that means there are active cases or people who've been shedding, but that's a real warning. And you go, I'm so glad that I wore my mask to work, because, you know, we can't get fresh air in and we can't keep our distance. I would be changing my mask every 2 hours. So I'd be asking the managers to really keep an eye on my staff, because you need to go to the loo and you need to hydrate. Certainly no drink bottles at work. Certainly, you know, you need to go to the tea room, which will be mask off, and get your drink. This virus is just looking for your throat. And if you've got your drink bottle on your desk, you're not going to be doing your hands every time before and after. And that virus is just going to, it'll find a place. And unless you're really just thinking, I mean, for people like me in Melbourne, it's pretty automatic. And I think it's really improved our level of hygiene hugely, just being really aware. I mean, if anybody sneezes here, you know, everybody, head sort of twists around and we give them a dirty look. And there are people sneezing without covering up, and boy, do they get dirty looks. So thinking about you, what is my situation at work? I'm not going to force other people to wear a mask, but am I over a certain age? Am I in a risk group? Wear a mask. Is it impossible at my work for us to keep our distance? Wear a mask. Okay? But be alert to the cases or what's happening in the sewage treatment works. So this is why I think a lot of you are a lot have been contacting me saying I can't seem to get really good guidelines, because we're really forcing you to do your own risk analysis. Easy for me. I would automatically wear my mask coming. I mean, we do anyway here in Melbourne. But how much work is done on the patient before they come in? Because as I said, you'll thank your lucky stars if when the patient does say, yeah, I've got a sore throat, would you mind waiting in your car? And the doctor will come out to you there. think of the effort and heartache and time that you've saved. So I was just going to stop there for a minute. And Jenny, do you want to weigh in with any questions? Because we should debate some of this, and people should put me through some rigour.
I don't have any questions through yet. I have unmuted everybody from my end. If anyone would like to speak, you just have to hit the little red microphone and it will turn green and you can speak if you wish. Or
Great.
alternately, type in any questions.
Okay, I'll just wait until people put their hand up. I think they've gone off to make their coffee, Jenny.
I think they're too shy. I think we'll just keep going.
Well, I mean, I hope I haven't frightened anybody, but honestly, I think sometimes we just need to be reminded of what's happening. If I can explain, this is a psychological thing, but what a lot of us are suffering from at present is what we call the prevention paradox. And that is, I can't see it. Nobody I know has got it. It doesn't exist. That is a really human thing. So I think it's human. So really forgive yourself if that's how you think, but that's what drills, keeps on whirring in your mind. What are they going on about? I can't see it. And yet here you are. You see yesterday the number of figures of deaths in the US. And, to me, that was more real in June because we had cases here and deaths. We're 25, 30 deaths a day or more. And it's real, even though I didn't see, I know people who've had it, and certainly a couple of my clinics. The reception staff got it because they had drink bottles and they were close. Don't start me. There you go. So there's the evidence. But now I don't know whether I've become sort of less engaged, but when I heard that there were, I think it was 3,000 deaths the other day in the States, it actually didn't touch me as much as the maybe 100 or more a day in New York, back in March, April. So are we becoming desensitized? Am I beginning to think I can't see it, it doesn't exist? But you must engage with the fact that, and we've got plenty of media telling us, and I'm telling you, there are between 8 and 18 positives a day being detected in Australia through overseas travel. And all of those people spend, up to 24 hours on the plane with others. Some of them will pull their masks down. Touching stuff, the planes we trust are cleaned, but people are going to have to take their masks off to eat. You can't starve people for 21 hours. And there will be people who will be cooking that virus getting on the plane. That's in fact the evidence, because they're turning positive when they come here. So is there a part of us as human beings that don't want to accept that? There's certainly a mean part that says, what are they letting them all in for? But I'm telling you that they're citizens with every right to return, and this has got a fairly low mortality. The problem with this, of course, even if I say it's got a low mortality rate, the problem is that it makes enough people sick to actually bring our hospitals down. That's the problem. So that when you have a motorbike accident, when you have a heart attack, when your little one has, anaphylaxis for some reason or asthma, no room at the hospital because it's full of COVID and the staff have got it. We saw that in Melbourne where staff got it. And things were running a bit tight. So it's not so much the disease itself killing a lot of people, that's bad enough, but actually the death rate is higher because other people who need to be in hospital can't get into hospital, can't have treatment, etc., etc. So that's why we nail the people keeping away from symptoms. Imagine somebody comes into your clinic, not checked, no questions asked, we're too busy to ask, sits down next to your transplant. Thanks for nothing. And that was because we couldn't be bothered. We were too busy. We were told there were no cases. Well, as I said, you're one Uber trip away, one flight, one delivery away. How good is your hand hygiene? Are you wiping the hand rub pumps over daily? You know, people are touching them, clog up with the gel, nothing attractive about a lump of dried gel on the end of that pump. What that means is nobody will use it. So please make sure they're wiped every day so that people are drawn to them. Lots and lots and lots of alcohol hand rub everywhere. There should be nobody who can't use it. It's very rare for people not to be able to use it, but at the same time, people need to be using a compatible hand cream, not some, you know, something from somewhere else. Are the staff getting sufficient breaks? As I said, I'm really concerned about where people are only given 2 masks, but you cannot put a mask anywhere once you take it off. The only place for it is the bin, and you're in the tea room, off, do your hands, now make your cup of tea, go outside, have your cup of tea, go to your car if you feel more comfortable there. One little leftover that clinics are telling me that they might keep up is they're liking the idea of scrubs. They keep a pair of shoes at work, and they're their work shoes, and they just change into their scrubs. And they have a couple of outfits. Some places launder for them, you know, it gets taken away. Others just pop it into a supermarket bag, take it home and wash it. So I know there are a lot of clinic families out there who are quite grateful that their family isn't sort of, you know, wearing suit and tie, etc., etc. So a lot of people are saying how comfortable it is to keep the scrub. So it's not silly. Loads of people are saying, you know what, we ditched toys and magazines, they're not coming back. Hallelujah. Why would you? People haven't like died because there were no toys to play with. Yeah, it's more likely that they could get problems because there are toys. So why bring them back? I don't think you'll not get accreditation. And if you've got a pile of magazines, just like give them away. Just say to people, you know, you're looking a bit bored or you've been here too long and, you know, you need to, here, have it. We don't want it back. Obviously, nothing, you don't want anything handed back. So toys, no. So all the things that we thought we had to have, it's really interesting. Don't sort of seem to need them. Linen, have we seen the end of linen in office-based practice? Well, it's entirely up to you, but I tell you what, as a patient, I'd much prefer a wiped down couch than linen that I don't know when it was last changed. So, as I said, we are in the middle of a global pandemic. And is it because you've got a rubbish, you know, treatment couch that you feel you need to cover it? So, you know, it's summer, maybe have some double sheets of, you know, Versatile or something to put down if it's a cold day or a hot day, or the patient stripping off. That's what I'm talking about. But generally, people going for a check or an examination who've got to lie on the couch, bare couch, just wipe down. So make sure the doctors and the nurses doing wound care, etc., have got plenty of wipes. I don't mind the lid being off during the day, just put the lid on at night and maybe just turn it upside down so the liquid, you know, can go through so we don't get too much evaporation. Possibly maybe use your detergent disinfectant wipe rather than just a plain cleaning wipe. It's pretty much up to you. I know another thing that I think will keep up. I'm just having somebody make a delivery, can you believe? I can't believe this. The person who is been doing the cleaning twice a day of the high touch surfaces. So keep that up. That is a good thing to keep up. The doorknobs, the handles, etc., the rails, wiping over lunchtime, wiping over home time. If you feel you want to give it the night job to the cleaner, fantastic. They're the things that I'd keep up. I'd keep that up. So I think there are things that we've learned through this year that are good, that we will keep up. My top ones would probably be toys, magazines, linen, and cleaning twice a day. Oh, I know, a patient's not waiting inside any more than about 10 minutes. In other words, call in the next patient so the doctor isn't missing a beat there. Sometimes the doctors actually prefer to go out to the car. Fantastic. So this is a way of keeping our waiting rooms less crowded, plenty of spacing, and how about we try and open some of those windows, as long as it's not a stinky hot day, opening the windows. A number of clinics have said to me, we can't do that. And I go, well, then you have to accept that is higher risk. You've just got to accept it. for as long as there are cases around. Others have said, we thought we could open them, but they've been painted closed. That's a problem for the owner too. A lot of you don't know how many air changes you're getting through your air conditioner, or whether it's fresh air or recycled. If you're part of a a shopping centre, these are real issues. And I've had a couple of clinics actually move out into standalone houses where they could actually go and see the patients on the street or in the car park, because they've said going down from the 9th floor to a car park to see a patient is impossible. They've ended up with all these patients in the lobby because they haven't got enough room for spacing. So there's been a lot of issues come up this year, and you've got to say, is this where we are a suitable place for the next year or so? Because this will be with us for at least a year, okay, until the vaccine comes through. And as I said, I don't know how long the vaccine's going to last. So any questions there, Jenny, at that point?
We do have a question. Do medical practices require a QR code?
Oh, they've got them going for aged care, haven't they? I think you've already got a system that says the patient has arrived, and I really don't mind, what you use for there. Go by your state, by the requirement there, but just say to yourself, if we get a tap on the shoulder and say that we had a positive patient, we've got a positive patient, and by the way, they were here, can I find that patient on my system? Do I know when they arrived? Do I know that they were inside? And do I know for how long? And do I know who else was here at that time? That's what you want your system to do, whether it's a QR code or not, because you're going to have to contact trace those people or give that list over to your public health unit. It's a bit like tracing and tracking for instruments. You want to know who else had procedures done from instruments sterilised in that dud cycle, if you like. Doesn't matter what system you use, it's can I do it? And so the QR, like I had to do a QR thing with my phone this morning when I went for a coffee and a pastry with my grandson. And of course the staff are all waltzing around with no masks. Well, make it easy for yourselves, wear a mask. But thinking about that situation, go back to your public health unit or your health department and see whether it's a requirement. But don't panic about it if it is and you haven't been doing it, but just ask yourself the question, do I know who was in that clinic at that time with the system that I currently use? That's what you want it to do. You want it to tell you who was here and for how long, and also you can ask the patients when you do the contact tracing, where did you sit? But I tell you what, patients aren't sitting in that waiting room for any more than 10 minutes. They've all got masks on. Beautiful. And it's even, in the guidelines, it actually says we tend not to then treat them as close contacts. That's the position you want to be in.
I have another question. What is a good approach? Symptomatic patient has COVID test Monday and has a teleconference, etc. URTI treatment. Still unwell on Wednesday with symptoms, perhaps even Friday. How long from a COVID test would you consider reasonable to accept the results as current and perhaps prior to a repeat, particularly as I assume COVID symptoms can change over time?
Yes, and the fact that the patient's not getting better can actually still mean they're still crook from COVID or the UTI. Well, we actually won't know. We tend not to try and, focus on it's only COVID. We know that. But you would also look at the fact that if they were negative COVID on Monday when they were symptomatic, and there's really not much floating around your local area, then, and they've got symptoms of a UTI and it's showing up, UTI, then, with a UTI, they should be getting better within 36 hours. We know that. And I know that antibiotics aren't always indicated for UTIs, but something else is going on in that patient and they require further investigation. I'd be very keen to see them, but in their car. Okay. I think what this person's also saying is, should I have them retested on even Wednesday? entirely up to you, but they've already tested negative with symptoms. Now, yes, it could be the wrong type of throat swab or nose swab. They didn't get it properly, but that's less of a chance thing. There's just not much around at present, although we always keep in the back of our mind our return travellers. So the person's still unwell. They've had symptoms really. What you're saying is 5 days. The symptoms are changing a bit. There's a lower risk that it's COVID than it is due to the UTI itself, and even some of the treatments for the UTI the person might be reacting to. But I don't think it'd be looked too kindly if I did 3 PCR tests that week when I also had symptoms of that were reflecting a UTI. I think the person is saying it's a diagnosed UTI, but the symptoms appear to be also COVID, and the COVID test is negative. That's what I'm hearing from that case. But if they've got symptoms of COVID, that they should also be isolating from the rest of the family, because they shouldn't be passing colds and RSV. RSV is an issue at present, respiratory syncytial virus. There's been an uptick there, and there's actually been a little bit of an uptick in flu. So I don't know whether your testing is for the respiratory panel or just COVID. Some of the pathology companies are only testing COVID, others are testing across that panel. So, this is I'm not a doctor, I'm a microbiologist. I know what the panels, I know what they're about, but if that were my patient, I would think that you'd want, I've got to be careful saying hands-on, but I think you know what I mean, that there just may not be enough from telehealth to keep me satisfied as a clinician, and I think I want to see that patient. The COVID might be a confounder. I just don't know what symptoms the person's turned up with, but obviously it's fever and signs that they've got an infection. I don't know whether they also had the sore throat when you're talking about symptoms, or whether it was more general malaise, and the UTI turned out to be positive. I'm not much good there, but I would really want to see that patient.
No more questions.
Okay, so as I can refer people to the little cheat sheet. But it's not a case of, I said you've got to do all these things. It's really about what's going on around me, and I've got to put myself in a position where I could be in the early stages of COVID. What am I doing to protect others today? Well, I keep my distance. I do my symptom check when I wake up, and I expect somebody to check me when I get to work. So it could be me. We're very big in healthcare. It's those patients, those sick, dirty patients. That's them. Not dirty, but you know what I mean. Those patients. No wonder they get sick. You should see them picking their noses, doing whatever. That's what we're like. But you know what? It's us. So what am I doing? Oh, we all take our masks off when we get to the tea room, pop our masks on the table and have a cup of tea. And this is what caused a big outbreak in northwest Tassie. 120 people, 12 deaths. I know it was one person working across 5 facilities, 2 hospitals, private and public, and 3 aged care, but that was what was documented. People getting to the tea room, oh, phew, I'm so exhausted working on that ward with those sick people, mask off on the table, no hand hygiene. Back to the face, people got sick, and they were healthcare workers. And of course, the story here at the Royal Melbourne, where there just was not ventilation, and they were cohorting COVID patients who, of course, they're really crook. They haven't got masks on. Some of them have dementia, and so you've got 4 patients in your ward, no ventilation, and the build-up of those small droplets was such that the ordinary surgical mask was not protective. That's not our situation in general practice, and it's not the situation in all, every single hospital unit. But this really made us realise we need P2 masks where we've got that situation of very poor ventilation, and we're cohorting our patients, putting them together. And so there's been for and against the cohorting. Oh, they didn't even have a separate bathroom for the patient. So you can imagine what risk that put staff at. So and of course a lot of this is just this human interaction. I'm fatigued, and people were just taking off their PPE incorrectly. And certainly we heard from nurses observing the personal care attendants just coming towards the staff room or the handover room in full PPE. I mean, you take it off at the door sort of thing when you're leaving the person's room. So, you know, I'm really on people's hammer about please don't start wearing the whole box and dice unless you actually know how to put it on and take it off. And pretty much now, I guess there's a bit more of a consensus about it's always gloves off first. Even a bit of a disagreement about doing your hands, but gloves off first, gown off, and then step outside the door and take off the rest. But that's when you've actually seen a positive. But for us in general practice, it's you can get what we call extended use out of the mask, which is you can wear it for a couple of hours, and then, you know, take it off, change it for all those reasons I mentioned. People putting gloves on unnecessarily. I would never hang my hat on glove use. I mean, obviously if I'm touching body fluids or doing procedures, etc. But people then just don't do hand hygiene when they take their gloves off. And then because of the way they take their gloves off, they self-contaminate. So the glove is actually doing no good at all. So I'm sure you've seen me do this a million times, but the correct way to take your gloves off, and if you've got a gown on, the glove goes over the cuff. I can't tell you how many nurses and doctors I've seen with it over. That's not correct. It needs to be over the cuff like that so that when you take it off, you grasp, pick up, and underneath and over, and hand hygiene. Remember, with 2 hands, all right? And you've seen me all do it 1,000 times. Too much investment in gloves when gloves actually weren't necessary. And then, of course, you've all seen people touch everything with their gloves. What they found out a few months ago was that, you know, we kind of didn't go off cleaning a lot, but we didn't know the role of surface transmission. And it appears it's more when gloves, contaminated gloves, you know, you've had your hands down somebody's throat doing some work with them, and you've gone and touched surfaces.